a few challenges to the surgeon. Authors have no financial interest to disclose. The first hurdle is capsulorhexis. The lens is eccentric and the anterior capsule is lax because of genular dehiscence. Once rhexis initiated, you proceed very slowly. The ideal capsulorhexis size should have at least a 2 mm margin between the rhexis edge and the equator to support the CTR later on. A case of a more unstable and eccentric cataract. Rhexis initiated by puncturing the capsule with a bent needle. To proceed further, you support the unstable lens with a hook in the left hand. When the rhexis edge starts vanishing under the iris, you use capsule hook at other quadrant to pull and stabilize the capsule margin. Once the rhexis procedure starts, you can support the capsular edge with iris hooks also through limbal stab incisions. In a grossly subluxated cataract in a young patient, long iris hooks probably can give better counter traction than other hooks. The next obstacle to overcome is bag stabilization in these unstable cataracts. After rhexis completion, the capsule margin is stabilized with multiple iris hooks through limbal stab incisions. Difficulty is that the bag is at a much anterior plane. Debulking the soft cataract creates space to introduce a standard CTR. Even then, the whole bag CTR complex remains anterior to the iris. Inserted manually, the CTR has its vector forces directed towards the area of genular weakness. In a harder cataract with iris coloboma, a central crater is made. Then before proceeding to chop, the capsule margin is supported with iris hook. Immediately a rhexis margin tear occurs. Capsular hooks are better capsule retractors as they are less liable to cause margin tear. They support the weak capsule by the equator and prevent its anterior migration. Prelimbal stab incisions for capsular hooks introduction prevents slippage of hooks during phacoemulsification and anterior tenting of the bag. Iris hook through the eyelet of Sioni segment can be used as a temporary measure for stabilizing the bag. Now the implantation of the capsular tension ring. Some surgeons prefer to introduce the standard CTR at the beginning of the surgery with the injector system. CTR insertion at the beginning of surgery in grossly subluxated cataracts may actually increase genular dehiscence. Others like to do it manually once a few nucleus segments have been removed. The bag supported remaining nuclear fragments are then emulsified with slow motion phaco. In this particular case, capsular bag is stabilized with Sioni segmental CTR. Fixing the CTR by hooking the eyelet with iris hook and also using multiple iris hooks for bag stabilization. Phacoemulsification is continued with very low parameters. Even then, the lax posterior capsule is caught at the phacotip. So the dictum regarding ideal timing for CTR introduction is as late as you can, but as soon as you must. Phacoemulsification of the softer nucleus can be done with irrigation aspiration only. Even using the Simcoe cannula can be good enough. In the harder cataract, once the first chop is successfully made, the second chop is done holding the hard nucleus almost at the same place, thereby creating a pie. Emulsifying one segment or pie is a better idea. This creates some free space for moving the harder nucleus. Subsequent choppings then produce less stress on the already compromised granular system. An innovative foot pedal controlled continuous visco-injecting device by a cannula through the left hand side port is unique at this point. It mobilizes the nuclear fragments, separates posterior capsule from phaco-tip, and disengages iris entangled in the phaco-tip during the emulsification procedure. At the end of emulsification, before withdrawing the phaco-tip, the visco pump keeps the bag inflated by injecting HPMC continuously. In yet another case of subluxated cataract, the capsular bag is stabilized with capsular hooks. After multiple choppings, fragments are emulsified slowly. Continuous visco injection in the anterior chamber with the visco pump prevents capsular catch by the phaco-tip. The high risk group with chance of progression of granulopathy needs long term fixation of the capsular bag. This is done by augmenting the standard CTR with segment CTR fixation. Once cortical cleanup is complete, the area of subluxation is visualized by relaxing the capsular hooks over that area. Ninoprolene suture with a straight needle is passed through pars plana from one side of the area of subluxation and retrieved through one of the corneal wounds at the other side. The capsular hooks are stretched a bit. A standard CTR is introduced in a direction supporting the subluxated area. Capsular hooks released, still the CTR bag complex is anterior to the iris plane. It is pushed back with the help of viscoelastic. The eyelet of an Ahmed segment fixed with the free end of the suture. The segment is then introduced in the bag and placed in position by pulling the other end of the suture externally. Multiple horizontal bites without knots secures the suture over sclera.
Now most of
and
the
fix
surgeons
segment
prefer to
CTR
do
internally.
augment pocket, but these are the basics of
Now with the bag well centered,
how
a
to
single piece
deal with the
foldable IOL
subluxation.
is injected in the bag.
Every
Conjunctival
subluxation.
closure with bipolar cautery over the area of scleral knot marks the end of a very successful management of ectopia lentis.
So every
you.
subluxated case is basically very different. You have to do the different approach for this every cases. But these are the standard guideline for dealing with the all subluxated case. Thank you.